Okay, welcome back folks for video number 3 in our series of videos. Now we're going to look at a ECG from a 54-year-old male who ends up having a dilated cardiomyopathy or non-ischemic cardiomyopathy. Take a look at this ECG. It's non-specifically abnormal. We can see, for example, again like our last patient, there's some P-wave abnormalities. The PR interval here looks a little long, and so does the P-wave duration. See, P-wave duration is about 120, and the PQ or PR interval about 210 or so. That puts this person into the first degree AV block range. Then we also see some abnormalities in the QRS, which is a little long, is a non-specific interventricular conduction delay, the QRS 114. And I also see a couple of other things. The QTC in this case is normal, that interval. But let's look here in the right precordial leads. We also see what's called the poor R-wave progression, another non-specific finding generally. We might see a Q wave over there in lead 3. Let's take a closer look at that lead 3. And, well, the automated call says it's not a Q, that it's an R. So probably not an old inferior infarct here, especially given the appearance of AVF. So no clear old inferior or anterior infarcts, just the poor R-wave progression. Now, the other thing we do see is a generalized T-wave abnormality, very poorly defined T-wave. You can see the automated system has a difficulty calling what the T-wave axis is because it doesn't know exactly where it is. You can see the poor definition of the T-wave out, especially in the lateral precordial leads. So those are the non-specific abnormalities. Let's move on. We'll start to run the recording, and we can see that we'll go into our advanced ECG applications again, and we will start again with our signal averaged A-ECG. We're about a minute into the recording, and let's look at our fiducial points. Let's make sure that our fiducial points are correct, so we always know that the information we get out in the parameters is correct. This is lead 1. Let's switch over to the vector magnitude, which is the main lead that we use, and those fiducial points look good to my eye, so I think I will trust our results. So let's go ahead and take a look at some of the parameters. We'll go to the 3D ECG, and you see we sort of light up like a Christmas tree on this patient. We have lots of red, lots of abnormalities. Starting up here, we see a big, huge spatial QRST angle in the 160s. So that's a big red flag. If we look at the loops themselves, compare these to the prior patients, what you see here is a much more posteriorly directed loop. It's a bigger loop, but it's also very posteriorly directed. You see that especially in this left sagittal plane, but also in that horizontal and middle plane there as well. And the T and the QRS are much more opposed in each of the individual planes as well. You see it here in the horizontal plane, 128 or 29 versus 47 for the QRS. And you also see that in the left sagittal, almost 180 degrees directed apart. The T wave over there at about minus 180. And the QRS peak is at about 0 degrees. Other abnormalities as well, a very small and low spatial ventricular gradient. And we see abnormalities also in the orientation of things three-dimensionally. And the spatial ventricular activation time, or VAT, is also increased. So we see lots of different and fairly severe abnormalities in the 3D ECG in this patient. Let's go on and have a look at QT variability. And we will switch out of the first eigenvector over into lead 2. And we can see this huge dissociation we have. Again, a flat red line, which is the RR interval variability. And then this huge QT variability that's basically doing its own thing. A big dissociation. We're seeing more verticality up there in the upper right. Probably worse than the last patient we saw that had the coronary disease. And if we go over to, HRV itself, and we can see again, basically a flat line on the tachygram. But these are interesting phenomena. This is basically a series of premature ventricular contractions, or PVCs. That's what you're seeing there. Sort of superimposed on a very poor underlying heart rate variability. You can see again the Seattle needle tower type phenomenon, very poor HRV. Out in the flats there are just the manifestations of the PVCs. We see that as the compensatory pauses and the earlier coupling intervals. And here in the spectrum, again, we're basically seeing nothing, which is reflective of very poor underlying heart rate variability. We go into the spectrum panel, we see that the Loom periodogram is the only one we trust here. That can be used on the fly in the context of the PVCs, whereas once we detect those PVCs, we basically just black out to the autoregressive and FFT. So the only legitimate spectrum here is that blue one on the upper left, which is from the Loom periodogram. So we have very abnormal HRV, as shown here, with the PVCs on top of the poor HRV. We have also, now let's go into the waveform complexity, and we see big values here as well. So we have very abnormal complexity in some of those non-dipolar values, probably worse than the last case. We're also dipping into some abnormality here in the QRS wave complexity as well. So abnormal T wave complexity, QRS wave complexity, abnormal QT variability, which is very severely abnormal. We see the superimposed PVC effect on the QTV as well in the upper right, and the abnormal heart rate variability, which we discussed, and finally the very substantive abnormal 3D ECG. So we're going to have to again go to our statistics and let the statistics tell us what this patient most likely has.